It's a privilege for me to introduce His Excellency Dagfinn Høybråtten. I've been looking forward to this for quite a while, and I'm pleased that the day has come that he is here with us at BYU and that he can speak to you. Currently, he is a member of the Norwegian Parliament and the leader of the Christian Democrat political party. The day before he left, he was nominated to become president of the Nordic Council, which is approximately 200 representatives of the Nordic country members of parliament to work together in common interests of the Nordic countries. He has a very distinguished public and political background. He has served as the Minister of Health. He served as the Minister of Labor. In fact, at the time that we had hoped that he would come once before, it was right after the tsunami disaster in Asia, and as Minister of Labor needed to remain to assist Norwegians who were caught in that situation, but we're delighted now that we can have that opportunity to have him come. We're most pleased to have his wife, Jorunn, with us. Would you stand so that the students can meet you? We're pleased that you would accompany your husband. We're now delighted to turn the time to His Excellency, and we welcome you to the podium. Thank you.
Thank you very much. Thank you very much, Vice President Peterson, and thank you for this opportunity to address this group of students about an issue that is important to everybody. That's what I really understood the day I took on office as Norwegian Minister of Health. Well, people said, "Poor guy. Why did you take that job? It's the worst job in the government." But at the same time, it's a job that affects everybody's life in some way or another. What I didn't realize was, until a few days later, that it's a job that everybody has an opinion on. And the most critical opinions come from those who have not much experience with the services. They are most critical to the services. But after a few weeks in the position of being Minister of Health, I had a few of those days when you wake up in the morning and everything is wrong. There's a hospital crisis or some other thing that you have to comment on, and you go in every channel, in every debate, in every studio to defend your policy and to explain and to discuss. And when I came into the last studio, which was a TV studio, I was really feeling like I was chewn and thrown out again, and I really felt very bad and worn out. And I came into this makeup room that you have to go through in order to come into the TV studio. And when the lady in the makeup room asked me this question, I was really refreshed. She said, "Mr. Høybråtten, have you already been to the makeup room?" And after having been through such a day as a Minister of Health and then get such a remark, you feel like, okay, it's not too bad. Well, just to give you a few facts, because even if I have learned that many people in Utah and especially on this university have background and links to Scandinavia and to Norway, I will not presume that you know everything. So I'll give you some facts first. Norway is located in Northern Europe. It's the size of it is about the size of New Mexico, 386,000 square kilometers, or 150,000 square miles. It's one of the most sparsely populated countries in all of Europe because it's very long. If you put a needle in the southernmost tip of Norway and turn the country around, you will actually get down to Rome or something like that. So it's a long country. It's a scattered country. The terrain is mostly barren, with high plateau and rugged mountains. Not so unlike Utah, but in many ways different. It's a long coastline, broken into by fjords. That is actually deep parts of the ocean cutting into the land. It's a challenge in a country like this to organize good health service, because health service needs to be where the people are, and it needs to be of high quality. And the combination of being close to the people and being of high quality is not always easy. The country has high employment. The income increase in the population as a whole has been vast, but an increase in differences we have seen among different groups. We have a very high employment rate, also among women, about 70%. It's very high compared to any country, especially in Europe. When we look at some of the health status data of the country, there's been a very positive development in when it comes to many diseases. We've had a dramatic decrease in the frequency of heart attack, 70% decrease due to preventive health care and change of lifestyle and better treatment. But we have a dramatic increase in cancer, as in many other Western countries. 80% increase in incidence and 50% in survival. We have had an increase in diabetes 2, typical lifestyle illness, but also in mental illness, an increasing number of people with depressions and personality disorder. When it comes to important lifestyle factors for health conditions and health status, we have seen, although we have initially a high level of tobacco consumption, it's been decreasing, and we have seen a rather strong shift in the decrease of tobacco consumption last few years due to a rather, I would say, aggressive policy against tobacco in the country. I'll give another lecture about that later this afternoon, so I won't go into that in too much detail. But just to tell you that in our national airport, Gardermoen, Oslo Airport, there has been a sign over the past couple of years telling, "Welcome to Norway. The only thing we smoke in this country is salmon." It was put up after my government introduced the ban on on smoking in public places, and I just learned that the health conduct of the Mormon Church has been critical, to be modest, to tobacco since the 1830s. So also in that respect, you are far ahead of Norway in this area. But I am a strong believer in many ways, in many respects, also in the fact that preventive medicine works. It works if you have clear goals and you are persistent in your work and you are scientifically based in what you do, then it's a lot of things possible when it comes to preventive medicine. I have given you a handout that gives more details on these things, so I won't go into all of that. But just stop for a moment on the point of health care expenditure. I would say it's not always a good measure of the healthcare status of a country. But it says something about the priority of healthcare. It may also say something about inefficiency of healthcare systems and waste of money. So that is to say, it's not always a good measure. But there has been a study recently. It was just published this August that compares life expectancy, or puts together life expectancy as an indicator for health status, and the share of the gross national product spent on health. And this report, called the Health Systems in Transition Profile on Norway, ranks Norway on top when it comes to life expectancy as an indicator of health status and the share of GDP spent on health. The health system in Norway is an ambitious part of an ambitious welfare system. It's a part of a Scandinavian and Nordic tradition of a high ambition in caring for people and securing people coverage of good quality services independent of their economic status. The overriding goals of solidarity and equality is the basis of the welfare state, and it's also the basis of our health system in Norway. It's written out in the Patients' Rights Acts from 1999, where the principles of access to health service and the goal to secure the population equal access to health care and of good quality is put into law. The principle of equal access to services is such that all inhabitants should have the same opportunities regardless of social or economic status or geographic location. And this is reflected in the way we have organized our system. It's organized on a national, on a regional, and a local level. The overall responsibility for healthcare rests on the Minister of Health, of course, and the national healthcare services. The regional level is represented by 5 regional health authorities with responsibility for specialized healthcare, hospitals, and a local level represented by the municipalities with the responsibility for primary healthcare, including care for the elderly. When I came into the Ministry of Health in 1997, there was a need for reform in different areas. And we identified the needs related especially to the lack of efficiency, the lack of national governance in priorities, and a very, very prevalent problem, very long waiting lists for hospital treatment, especially the elective or the planned treatment. So we also identified some low priority areas that had fallen behind in the healthcare system and needed to be reformed. One of the areas was the area of mental health. You know, mental health has a tendency, I think, all over the world to fall back in priorities in healthcare, because systematically people who suffer from mental illnesses oftentimes have a weak voice in the public debate and seldom have strong patient rights groups behind them to put their case before public opinion and the public debate. At least that's the case, has been the case in Norway. And if politicians and those responsible are not aware of this, then you can end up, as we did in Norway, with a system that really was in the process of breaking down, where we could. My predecessor, Gudmund Hernes, who has also been here on this lecture like this, he made a white paper and put forward the diagnosis of the mental health system in Norway, telling that everything really was working very badly. The patients didn't get the treatment they needed, and the professionals didn't think they got the job done, and there was bad organization, there was bad priority, and there was a dramatic need of a reform. So I took over, and it was my job to make the plan out for the reform. What we focused on was how to get a better treatment, better preventive measures, better municipal services locally, better access to specialized services, and better knowledge about the follow-up of patients after discharge from hospitals. This is one of the most difficult tasks I have taken on as a Minister of Health, and but also one of the most meaningful. I remember one day I was leaving my office in the ministry, walking, as I did at that time, down to the ferry to go home. And I met this gal with whom I studied 15 years earlier. And she told me about a life that hadn't gone so well. She had been in and out of mental hospitals and had really suffered a lot from this lack of services. And she looked into my eyes and she said, Dagfinn, you see, now I'm one of those you are fighting for. I think I never in my life as a politician and a public figure have ever got stronger feedback from anyone than this. Because she had noted something that was very important. She had noted that there was someone out there fighting for her and for her services and for her cause. And that is really what gives me meaning as a public servant, as I see myself as a politician. We made up an 8-year action plan, an escalation plan to escalate the resources going into mental health, to change the different structures, expanding and reorganizing mental health services, focusing a lot more on low threshold available local services, strengthening the user's position and emphasizing public information, and organizing. We put a lot of money into organizing the users' organizations so that they could have a stronger voice in this whole battle for resources. We strengthened the municipal services, expanded and restructured the services for adults, and expanded and restructured the services for children and adolescents. But it was also a plan made with a very broad perspective. We said, I think it's the first health plan in Norway where we said that health is about body, soul, and spirit. It's not only body and soul, but it's body, soul, and spirit. And so jobs was a part of the plan. Housing was a part of the plan. Cultural activity was a part of the plan. The strategies was decentralization. It was putting a much stronger focus on follow-up of the patients. And of course, most important, a lot more money into it. The results so far, we're now towards the end of the action plan. It's going to be fulfilled next year. There has been much more focus and more responsibility to the local level. We have built 3,500 housing units for mentally ill. We have created between 3,000 and 4,000 new jobs in the municipalities, primarily for helping out patients. And we have made a lot of efforts to help to get a job and socializing in the local environment. But still, we have lack of treatment possibilities on a specialist level. What we see as a consequence of this plan is what you often see when you build a new road, a new highway. You think that the larger capacity will make it a lot easier to access and to get along the highway, but more capacity fills up very easily, because capacity reveals a greater need than you have seen before. And that has also been the case with the mental health escalation plan. A second major health reform that was initiated in my time as a minister, it was decided in my predecessor's time, and then I came back and put it into practice. So I had 2 terms as a Minister of Health. That was the reorganization of the Norwegian hospitals. We have very few private hospitals in Norway. We have about 300 private beds and 14,000 public beds. But these public hospitals, this public hospital sector was run by 19 different owners, that being the counties, and they were run rather differently. The cooperation between the hospitals were not good enough, and the use of resources then didn't become efficient enough. What we did was 3 things. We decided that the state would take over the public hospitals. They were already public, so it wasn't too much of socialism actually. But instead of being owned by 19 counties with different ways of running hospitals, it was owned now by the state, with the Minister of Health as the responsible person for all hospitals, with 5 regional boards running the hospitals in each of the regions, but answering to the Minister of Health, and the Minister answering to Parliament. Then we changed the ownership. The second thing we did was organizing in the regions. And the third thing we did was to give the patient a free right to choose any hospital on a given level of treatment. And we changed the financial system so that the money would follow the patient. And the idea behind this was to stimulate the hospitals in their running efficiently, but also stimulate them in pursuing quality. And also give the patient a power, so that the patient had the power to choose a hospital over another, and in such a way influence the flow of money to a hospital. We also made an information system on the internet, so that with quality indicators for the different hospitals, so that patients and their doctors could follow the development of quality indicators on the different hospitals. The goals were to improve the quality, to improve access, to improve continuity of care, and to ensure more a better patient-physician relationship in the hospitals. The hospital reform has now been running since 2004. No, it's in 2002, and it's been successful in some ways, not so successful in other ways. It's been successful in the way that the waiting list for patients have been cut dramatically. We have seen mergers of hospitals, and at the same time a pressure on how to use the resources, not in the core activities of the hospital, but in the support activities of the hospital. And we have seen a strong focus on quality. At the same time, many people think that there is a deficit of democracy in this hospital reform, because it's a centralization of power, and the local influence on the running of the hospitals has been reduced, which was part of the point with the reform. But of course, some people like it, some people don't. The third reform that was introduced in this time was the family doctor reform. In Norway, we have a system of local responsibility for primary health care, including the general practitioners. But we had a big problem with general practitioners, an overflow of general practitioners in the urban areas, and the lack of practitioners, general practitioners, doctors, in scarcely populated areas along our coastline. And when I describe the character of the country, you can tell it's different. It's difficult. What we also saw was that there was a lot of doctor shopping especially in the urban areas, which means that patients will go from doctor to doctor, and there was not one doctor having a strong responsibility and a strong feeling of responsibility for each patient. And we wanted to change this. We wanted to grant the patient, the inhabitant, a right to choose their doctor from a list of possible doctors. But we also wanted a good use of the doctor resources so that we could have a better distribution in the country of health services on a primary level. And we wanted to strengthen the doctor-patient relationship. And what we did was that we made a patient list system which provided a new model for employing GPs based on contracted physicians in private practice, where capitation, fee for service, and out-of-pocket payments form the total income of the doctors. Every inhabitant was given the opportunity to have a regular family doctor under this list system, and the municipalities had to meet this obligation by signing a sufficient number of contracts with GPs. At the same time, we put a cap on employing new doctors in the hospitals because most of the doctors wanted to work in the hospitals in the urban areas. And by putting a cap on employing doctors in the hospitals, we forced doctors to apply for positions in more scarcely populated areas in the primary healthcare sector. At the same time, we increased dramatically the capacity of educating new doctors. And this has, to a large extent, done away with the problem of lack of doctors in scarcely populated areas. We have now a much better capacity of doctors in local districts. At one time, there was a joke going that in some of the local areas you were lucky if you had a doctor at all, and if you had a doctor, you were lucky if you had the same doctor during the whole consultation, because the stability of the doctor service in these local areas had been quite a challenge. It's still a challenge, but it's a lot better after the reform. Based on a registration system and the patient's freedom to choose, and the right to choose another physician as the GP if they are not satisfied, and the right to a second opinion from another general practitioner, now the whole population, practically speaking, have signed up for one doctor as their family doctor. 98% of the population have chosen to be a part of this system. They don't have to, but they have a chance to. These are three examples of reforming an ambitious health system by changing some of the incentives, some of the ways we organize things, and focusing on the outcome for the patients. I must, though, come back to where I started about the issue of preventive health care, because I know nothing in politics that is so in such degree is not rewarding as fighting for preventive strategies. You know, as a politician, it's very nice when people come to you and give you thanks for what you have done. But it's very rare that people come and give you thanks for something that did not occur. And fighting for preventing disease, preventing illness, preventing accidents. It's oftentimes, not always, but oftentimes, fighting for something that should not occur. So I never experienced people coming up to me and say thank you for that my child was not in that accident, or thank you that I didn't have a heart attack, or I wasn't struck by cancer. But nevertheless, I think it's one of the most important things a politician can do, is to see to that there is allocated enough resources to preventive work, and see to that you have good strategies for preventing accidents, illnesses, and so on. I believe very strongly that if you do that on a scientific basis, and you have clear goals, and you stick to your goals over a long period of time, you will be rewarded. If not by your voters, maybe by their children. It's a long-term strategy, but it works. It's very, very sad that in our country we'll have in the coming 30 years we'll have a 20% increase in the occurrence of lung cancer among women. And the extraordinary sad part of it is that you can not do anything about it, because they have already smoked too long. But we can do something about their children if we do it now. I was asked by a journalist when I entered office in 2001, in my second term as a Minister of Health, what will you do about this increasing number of young people smoking? And I said, well, reduce it. And he said, how much? And I said, substantially. And the journalists were still not pleased, so he said, how much is substantially? Well, we should be able to half it. Half the number of young smokers in the country. And he said, how fast? And I said, soon. And he said, how soon? I said, in the course of a couple of years. In the course of some years. And he was still not pleased, so he said, how much is that? And I said, 5 years. And then it was in Aftenposten a big article with the headline, Minister of Health will halve the number of young smokers in 5 years. This is why how the goal was set. This was almost like John F. Kennedy, a man on the moon by the end of this decade. He was said not to have asked any advisor before he set the goal. But as in his case, the advisors came afterwards and asked, do you want to know what it takes? And I said, yes, thank you. Ja, tack. And they came up with a report a few months later based on the knowledge we have in the world about what works and what doesn't work in preventive work against tobacco. And they had 5 recommendations. And one was tougher campaigns. The second was stricter follow-up of the rules of selling tobacco to minors. It's prohibited to sell tobacco to minors in Norway. Better programs in the schools to teach the students about the consequences of smoking. And then they recommended to abolish the most important arena for recruiting new smokers, restaurants and bars. Prohibit smoking in all restaurants and bars. And I said, okay, we'll do it. So we did all the 5 things. And in 5 years, we had half the number of smokers among young people in Norway. So this is not just a very, very nice success story. It's scientifically based and proved. But I mention it here just to say that it's possible if you set goals, if you base what you do, your actions, on what knowledge can give you, and then do it. Not just talk about it, but do it. And do it over a concentrated period of time, but endure when things get difficult. We made what we call a prescription for a healthier Norway, a broad public health report addressing not only smoking, but addressing the main risk factors in Norway, as it is in all industrialized countries. Tobacco, alcohol, high blood pressure, high cholesterol, and obesity. Showing that lifestyle factors such as nutrition, physical activity, tobacco and alcohol and other drugs are strongly related to the expected lifetime and sickness. And laying out strategies to try to encourage better lifestyle. And that can be done mostly by knowledge and information, to some extent by regulation, but always by setting goals for what you do in the public area. Recent reforms has focused on these areas in Norway, and I think it's given me the experience that it wasn't too bad of a job. It was a lot of fun. It was a lot of meaning. And it is possible to change heavy systems if you know your value basis, if you know what you want to do, and if you are able to gather support around what you're doing. Thank you for your presence, and if you have any questions, I'm happy to answer the few moments we have left. Thank you.
We have just a few minutes. The lecture is being video recorded and audio recorded, so we'd ask that you wait for the microphone to get to you, even though I know it's a small room. It helps in the recording. So if you have any questions, please. Right up here. Right up here.
I'm intrigued about what you're doing by way of preventing mental illness, and if I picked up correctly, jobs, housing, cultural activities, socializing, the local environment are part of it. I wonder if you've looked at nutrition and alcohol use as factors in mental health.
Yes, these lifestyle factors is also very important in the area of mental health. And There's been some research in Norway done on the importance of physical activity in not only preventing mental health. It's important in that respect, but it's also important as a part of a treatment. We have also become more and more aware of the combined problem of alcohol and drugs, I should add, and mental illness. And much of the treatment, the challenge in the treatment now is to be better in treating both the drug problem and or alcohol problem and the mental problem. So we have more services now focusing on these what we call double diagnosis. And as you mentioned, I think when it comes to nutrition, eating and drinking the right thing, it's so important in preventing illness in general. As a public health strategy, it's easy to focus on energy going in, energy going out, nutrition, eat more fruit and vegetables, drink less, smoke less, the best is not at all, and exercise more. And these are strategies that are common for many of the most important causes of early death and illness.
Could you tell us a little bit more about the Green Prescription Program?
The Green Prescription Program is challenging the doctors to focus on lifestyle, not only on medicine, on the chemical side of it. My background is from the National Insurance Administration, financing the doctors' prescriptions, among many other things, pensions and so on. And my experience was that doctors needs some economic incentives and oftentimes a form to be encouraged to change their behavior. And we wanted to encourage doctors to focus more in their relationship with their patients on changing lifestyles when that was medically proven to be the best. Typically, in some cases of diabetes and high blood pressure, we made a form. We made a green prescription as compared to a blue prescription, which is the medical or the chemical medicine. And we also negotiated with the doctors' union reimbursement for doctors who made the green prescription. The green prescription would then, in areas where it's proved to be a good alternative treatment to change lifestyle instead of giving pills. I must say that the initial evaluation of the green prescription scheme has been very critical. The doctors have not, in general, have not liked to have another form. I suspect that the reimbursement was not high enough. But I think to some doctors it turned out to be a bit too bureaucratic. Whereas it was meant to be a tool in their daily practice, it's maybe seen to be more of an obstacle. So the people responsible now are trying to change it so that it can be more suitable to the goal that was initial. The initial goal of it.
I was wondering, besides the policies you guys implemented to half smoking in certain areas, public facilities, how much effect do you think the campaign, the government and political campaign that was advertised to your country to stop smoking was effective, opposed to just the policies?
I will go more into this in the lecture I'll have for health students later in the afternoon. But in general, I would say that we have evidence that the campaigns, the first campaign we ran, was very tough on showing the medical consequences of smoking, and it literally helped thousands to stop smoking. Probably around 100,000 Norwegians stopped smoking as a direct consequence of the campaign. The second campaign we ran was more a critical campaign towards the tobacco industry, joining in with the WHO and in exposing the way the big tobacco are thinking. So it was more a long-term building of attitude than really attacking the consequence of smoking directly. But I think this is a big discussion between researchers. What is the effect of campaigns? In general, you can say that campaigns have some effect. Unpopular campaigns have more effect than popular campaigns. Controversial campaigns, I mean, has more effect than uncontroversial campaigns. But I don't believe in campaigns as an isolated thing. You have to do it together with all the different other strategies if it is going to work, and then it will feel as a big pressure, and it will work much more effective, I think.
If I could go maybe a little bit more to the political side of things, I know that your reforms have been wildly successful and I think personally very good, but you have had your critics, particularly I know the Dagbladet and some of the other newspapers have criticized you for having a hidden fundamental agenda or some sort of Christian agenda underneath these reforms. How do you respond to these critics who kind of say you're the mørkemann, you're the dark man underneath, so to say?
Well, I think the combination of scratching into lifestyles of people and the fact that I'm a believer is a combination that challenges some people in the public debate more than if any other person would do it. And of course, it's been a price to pay because people don't like to be told how to live their lives, and basically that's not what I want to do either. But when you prohibit smoking in restaurants and bars, some people feel that that's going too close to my private sphere. And I remember I had a big debate with one of those critics, Professor Fugelli. He's a professor of social medicine at the University of Oslo. And he was quoting John Stuart Mill, saying that you should not you should not infringe the freedom of the individual. But he quoted only that half and not the second half of John Stuart Mill's social liberalism, which I think is a very, very good way of thinking liberalism. He said, as long as your exercise of freedom does not infringe the freedom of others. And when it comes to environmental smoking or passive smoking, it's exactly that, what is happening. My freedom, when I smoke in the proximity of others, it infringes the freedom of others. So I think if you go behind the slogans and the labeling of in the debate, which is a very bad way of discussing things, I think, and see what is this really about, I think it's in line with the best liberal ideas of our democratic societies.